My name is Sarah, and I'm going to be presenting my case study today. My case study is on arterial venous fistulas, fistula complication, failure, and intervention. An arterial venous fistula is a surgically created connection between an artery and a vein. An artery venous audulogous grafts are also used in place of an arterial venous fistula anastomosis. Fistulas and grafts are used for patients that need hemodialysis due to kidney failure. Maintaining the patency and flow rate of vascular access in patients undergoing hemodialysis is critical to reducing morbidity and mortality. Fistulas and grafts often have frequent complications and are at high risk for failure. Duplex studies are important in monitoring their status. I did my case study on an established patient at my clinical site. The patient came in for an emergent fistula evaluation duplex after access was failed at the dialysis lab. The patient has a history of chronic stage 5 kidney disease, type 1 diabetes, hyperlipidemia, hypertension, and renal insufficiency. The patient had a radiocephalic fistula created in 2012 that had multiple interventions performed before total failure in 2016. In 2016, a brachial axial with a bovine carotid graft was created. In 2018, the patient underwent angioplasty of the graft and angioplasty and stenting of the axillary vein outflow. 12 days ago, the patient had mechanical thrombectomy without TPA and angioplasty of the graft. At that time, the fistula was working well. During the ultrasound examination of the fistula, a hyperechoic thrombus was noted at the arterial anastomosis and proximal fistula. This caused a total occlusion of the fistula at the proximal mid-distal, also at all outflow levels. Reconstitution was noted at the proximal axillary vein. With further evaluation, both proximal and distal subclavian vein was noted to have continuous venous flow, which suggests a more proximal stenosis. Due to patient habitus, we were unable to obtain anything more proximal. Due to the results of this examination, the patient was taken to the on-site outpatient vascular lab where angioplasty was performed. I chose this patient in this case for my case study because he does show a lot of different complications and possible interventions. The possible complications would be aneurysms, infection, ischemic steel, thrombus, and venous hypertension. Aneurysms can be caused by multiple punctures to a small area, causing the wall to weaken and an aneurysm or pseudoaneurysm to form. Infection during fistula creation or during dialysis are both possible. Grafts are at a higher rate of infection because a foreign material is used to create, versus a fistula uses the patient's own anatomy to create the fistula. Ischemic steel syndrome is when there is a reduction or a reversal of flow in the artery distal to the fistula. Thrombosis can be caused by a number of factors, including scar tissue forming from repetitive needle punctures and the body's natural response to an abnormal change in the pathology. With pathological changes from surgical intervention will increase the thrombocyte activity, which will lead to the anastomosis becoming stenotic as the body tries to close off the abnormality. The cause of venous hypertension is a stenosis either at the venous anastomosis of the graft or within the vein proximal to the fistula. When the stenosis in the outflow from the fistula, less blood is able to return, causing an increase in pressure in the outflow vein. The patient chosen for this case study is a prime example for common forms of intervention. The common types of intervention for thrombus in venous hypertension are angioplasty, mechanical thrombectomy, and stenting. A large majority of studies agree that endovascular intervention includes greater than 50% stenosis of the outflow vein or the central vein, causing 50% decrease in volume flow in absence of normal polyphasic central venous waveforms. For ischemic steel syndrome, a drill is performed, which is a distal revascularization and interval ligation. This requires a graft to be connected at the inflow artery proximal to the arterial anastomosis and then connected to the native outflow artery distal to the arterial anastomosis. The native inflow artery is then ligated distal to the arterial anastomosis to stop the retrograde flow. The new graft will take blood prior to the fistula to feed the native artery distal to the ligation. Interventions for large aneurysms are all dependent on the surgeon. Not much research has been done on this prior to that. The organization Fistula First, Catheter Last focuses on supporting the renal community in efforts of improving vascular access outcomes. The mission is to improve survival and quality of life of hemodialysis patients. This is achieved by spreading successful ideas, close fistula monitoring at the vascular labs, collaboration between patients, networks, and healthcare professionals.